Services. This is our first in-person meeting since 2020, so it is good to see all of you. We have two budgets before us today, and we are going to hear them in the following order. We'll begin with the Maryland Department of Health Regulatory Commissions, and then we will follow that with the Department of Aging. So if there are no questions or comments from members, we'll go ahead and begin with analyst Andrew Garrison. Good afternoon, sir.
Good afternoon, Senator, Madam Chair, members of the subcommittee. Glad to be back. We should be putting on the screen in front of you all in a little bit here the budget analysis for the Health Regulatory Commissions. Of course, this budget includes three commissions that we traditionally talk about: the Maryland Healthcare Commission, or the MHCC, the Health Services Cost Review Commission, or HSCRC, the Community Health Resource Commission, or CHRC, and then additionally this year, now separated out in its own budget line, is the Prescription Drug Affordability Board, which is included in here as well. So first, to get things started, we are showing the funding for the governor's fiscal 23 allowance here. We are seeing an increase of about $70 million. It's a pretty sizable increase, and actually a lot of that increase is happening in the Community Health Resources Commission. And those increases also, as we're showing here in that yellow bar, are predominantly specially funded. And those are because of two new initiatives, legislative initiatives that you all passed in the last couple of years. The HERC grants and the consortium, which was a blueprint initiative. We'll be talking about those a little bit more in depth later on. But the first thing I want to highlight is a lot of the dollars in this budget do go towards particular grants and programs. So we've broken those out here in front of you. In Exhibit 1, we have the UCF is the Uncompensated Care Fund. That's a rebalancing initiative between the hospitals and the uncompensated care that they provide, managed through the HSCRC. And then we also, towards the bottom of this exhibit, have those two new grants that I mentioned, the consortium and the HERC grants, making up a pretty sizable amount of the dollars that we see in this budget. And then the last third is looking at some smaller grant programs and the actual operating expenditures of these budgets, which we're showing here in Exhibit 2. And so now this is then focusing just on that 1/3 of the budget from the prior exhibit. And even when we narrow it down here, we still see about then half of this $80 million is going towards different grants as well. We have some operating support for CRISP. We have grants to both Shock Trauma and the Trauma Physicians Fund. And then the kind of traditional Community Health Resource Commission grants to nonprofits. And then on the other side, the pie chart off to the other side of the screen there has the actual operating expenditures of these budgets, with the two largest being the HSCRC and the MHCC, both at about $20 million of special funds. And then those budgets as well then contribute a little bit of support to the Maryland Primary Care Program Management Office. They each contribute $600,000 for a $1.2 million contribution to that program. The Prescription Drug Affordability Board is down there at $1.4 million. And then the Community Health Resource Commission has the smallest administrative component of their budget at just about $1 million. For the changes that we see in this budget, again, the amounts in particular I want to focus on are in that Community Health Resource Commission towards the middle here. It's about a $50 million increase from the consortium, and then another $15 million in from the HERC grants. And speaking specifically on the CHRC, what we've shown you here in Exhibit 4 is the historical expenditures of the CHRC, and then what the kind of out-year plan spending looks like with some of these new legislative initiatives. So the blue bars are what the Community Health Resource Commission has traditionally done. Those are operating grants to smaller nonprofits, kind of innovative programming, particularly focused on safety net providers. And that comes in usually about $8 million a year. As you all might recall, the funding purpose, or the funding source of that rather, has switched recently. It went from the premium tax credit exemption from the Care First Fund to the reinsurance program fund, but that is only available through 24 through statute currently, and so we are asking the department to comment on the availability of funding in the out years for kind of the traditional work of the CHRC. Also, then our green bars in front of you are the HERC grants. This was legislation that you all passed, I believe, just last year, Chapter 741, established a $15 million funding for the health equity resource communities. And there was actually supposed to be funding in fiscal 22 for that purpose as well from the Relief Act, kind of a pathways to HERC is what it was called in legislation. And that funding has yet to be reflected in the fiscal 2022 budget. And we are also asking the department to comment on the availability of those funds in 22 because the CHRC has reported that they do plan to spend those funds that were appropriated by legislation. And then lastly, we do have the consortium there, which is those big purple bars. Again, this was a blueprint initiative, and it grows really, really quickly. And right now, through 2026, the really only operations of this agency is going to be the consortium grants. And the CHRC itself has also increased in their operating capacity to administer these grant programs. They've added new positions in this allowance in order to manage both of these funds that are coming in there. The other thing I would like to highlight when we talk about this budget is about the hospitals and particularly hospital responses during COVID because we do the health regulatory commissions in front of us. And so what we're showing in Exhibit 5 here is hospital volumes and revenues. This data is available right now through July of 2021 that we're presenting here, and we're looking at as you can see, during the onset of the pandemic, and actually let me just scroll a little bit here, we have really an initial downtick in the admissions that were going into the hospitals. However, the revenue and the dollars that came in were able to stay fairly level, and if not above prior year levels, really, I think, highlighting the Maryland model in the global budgeting system, allowing the hospitals to have a certain amount of financial stability that a lot of other hospitals in the nation weren't necessarily afforded. The other thing that we were interested in looking at was specifically the impact that COVID admissions had on the hospital system. And we were looking here at specifically COVID positive admissions. The data that we were able to access had different coding for COVID positive. So these are just folks that tested positive for COVID. Of course, the hospitals were busy treating people who had COVID-like symptoms or perhaps known COVID exposures. But this is really, again, those known positive cases that we were able to find in the data. And we see that they never really took up enough of the hospital beds to really increase that volume back to the point of kind of those traditional levels. And at any given time, we're still under about 15% of the total hospital beds occupied during the data that we had available to us. The other thing that we were interested in highlighting is seeing if the folks who were coming into Maryland hospitals for COVID looked different than sort of the traditional hospital admissions and expenditures that we have here. And so the first two bars that you see are pre-pandemic, and we've broken those up by payer. So the blue bars are the Medicare population, which is really what we want to focus on, because as you can see, they had a relatively smaller share of their admissions into the hospitals in the pre-pandemic phase. But then when we look at those folks who came into Maryland hospitals after testing positive for COVID or having a COVID positive test during their stay, they took up a higher share of that. So suggesting that the folks who were ultimately hospitalized in Maryland hospitals did probably skew a little bit older because Medicare was their primary payer for that. The other thing to highlight on this discussion around COVID-19 and the specific impact on Maryland hospitals is what we're showing here in Exhibit 9, and this is looking at the revenue impact. And so what we have here is what the projected impact might have been under a more traditional healthcare financing model, kind of a fee-for-service model, which is really dependent on sort of the volume of admissions and the services being offered there. And of course, that would have suggested a pretty substantial loss, given that admissions went down quite a bit. But with some of the flexibility and the financial stability that the state's model and the HSCRC is able to offer, from the financial side of things, the Maryland hospitals were able to fare fairly well during the pandemic. Of course, we do know that this does not capture any sort of increases in operating expenses, any increased pay to staff or surge capacity. This is really just kind of dollars in, dollars out. But we still thought it was an interesting thing to present when specifically talking about the benefits of the Maryland model. And with that in mind, DLS is making a recommendation around the benefits of the Maryland model to Maryland hospitals, particularly during the COVID-19 pandemic. And what we're particularly recommending is that comparison of how Maryland and Maryland's unique healthcare financing system really was able to provide some stability that hospitals in other states weren't able to afford during this period. The last thing I want to highlight is the total cost of care model and the state's performance on that. The program year 2 was certified with Maryland meeting all of their goals. And in particular, Maryland continues to perform really well on their savings to the Medicare program, which we're showing in Exhibit 10 here. And what we've done is, because the state has been able to save above their target goals, some of those savings have been able to carry over into future model years, making the state's work in terms of saving and generating savings a little bit easier. However, we do have some concerns, particularly around the guardrail, which is the growth of costs relative to other states or other peer states. And the HCRC reports that this is trending in the right direction. However, particularly, again, given the unique finance system that we've had, it's not surprising that our costs are a little bit above where the rest of the nation is. So we are asking the HSCRC to comment on update available to that and making sure that we're able to meet that goal as well in the next model year. And another component of the total cost of care model, and also these budgets contribute a little bit to the Maryland Primary Care Program. In the last 2 years, the Joint Chairman's Report has requested an evaluation of the Maryland Primary Care Program. And what we're seeing here in Exhibit 11 is the results of that, where in the most recent year, we actually are starting to see some cost savings from this program, fairly modest, and certainly 2020 was a unique year in healthcare and healthcare financing. And DLS has found a lot of value in these reports and evaluations, and so we are asking for making a recommendation for this continued reporting on this model. The other component of this evaluation last year was particularly looking at the racial diversity of the primary care program, and so that's presented in Exhibit 12. And here what we're showing is that outer ring is the participants, the racial diversity of the participants in the primary care program, and then the statewide demographics on the interior circle. And as you can see, participants in this program are disproportionately white relative to the rest of this state. I will also note that at the time of the reporting, the race or ethnic diversity of the providers themselves was unavailable, and so the only thing that we do have here is the diversity of the participants in the program, the beneficiaries for this. And the other aspect of this program is, and certainly these are primary care providers on the community, and the state and part of the total cost of care model includes broader population health goals. So we do have a recommendation here for, in addition to that kind of standard evaluation reporting that we've been asking for, to also evaluate the primary care program and its and how it's helping the state achieve some of those broader population health goals. In particular, there are some outcome-based credits that the state has been able to receive against the total cost of care model, and seeing if there is any interaction or way that the primary care program can assist with those. That does conclude my presentation, and I'd be happy to take any questions.
Okay, thank you very much. Are there any questions from the subcommittee? Senator Eckert and then Senator Rosapep.
I actually have 3 questions. Am I allowed to have 3 this go round?
I don't know. What do you think? Okay, yes.
All right, first off, in one of the pie charts, you showed the Maryland Trauma Physicians Fund. Did we have any evaluation on that or any information on that and its impact at all this year?
I'm not aware of any evaluation that we've had on that, no, Senator. I can certainly look and see if we do have some reporting there.
Great, thank you. And then on the chart on page, Exhibit 5, where it looks at total hospital volumes and revenue, was there any breakdown, rural versus metropolitan hospitals? This is all hospital
Correct.
volume, correct?
Yes.
But I'd be interested in what that looked like throughout the state.
Yeah, we do. I do have this data rolled up by hospitals. I can certainly break it out by specific hospital and look at those for you as well.
Just to see if there are any trends or patterns.
Mm-hmm.
Thank you. And then the other one, is there any tracking on the amount of uncompensated care to know whether it's going up or down?
So I do know that the expenditures itself that are budgeted for it are traditionally going down. The HSCRC is here as well, and they might have more specifics around some of the trending there, but the fund itself is going down. However, That is also, the fund really just represents kind of the rebalancing of it, so I don't know if more broadly uncompensated care has been increasing or decreasing.
Thank you. Thank you. Thank you very much, Madam Chair.
Of course, and if you have one more, we'll let you come back later and ask
All
it.
right.
Senator Rosapep.
Thank you, Madam Chair. Let's start with Exhibit 5. I'm trying to understand it. So, again, I print these out black and white, and I guess these are in color. So, the bars are, the bars are admissions, and the squiggly line is dollars? Mm-hmm. Okay. So, obviously, the admissions went down with COVID, obviously. And then they've gone back up, but not to the level they were before. But the dollars went down and then have gone up before where they were before.
Correct.
Help me understand why.
So the state's model has allowed sort of the flexibility for hospitals to still charge up to sort of what would have been expected in a non-pandemic period under kind of a, still meeting their global budgets. So with some additional growth in terms of rates and adjustments, but effectively our hospital revenues are less tethered to admissions than other hospitals in the state.
In hospitals in other states. So, but that's why the dip came before the rate commission gave them higher rates? Is that the essence of the issue?
The dip in dollars?
The dip in dollars in, the big dip in, I guess, March of 2020, yeah, March, yeah, or April. You see,
So-
see the dip?
Oh, yeah.
Big dip in dollars.
Yes, so the commission's here and they might be able to speak on it specifically when some of those actions took place, but broadly, the commission did act relatively quickly in allowing some of those charges to.
So they basically just raised rates on the people who came. I mean, that's the essence of it?
I think in essence, yes.
What's the other sense?
Well, the allowing the charges to reflect what the global budgeting was.
Right,
Yeah.
you take the global budget divided by the number of admissions, and therefore we pay more.
Yep, yep, yeah.
They pay more per admission.
Yes, certainly, and we do have
Okay,
an
okay.
exhibit that reflects that as well. Exhibit 8 looks at
Exhibit 8, let me just relate to
the total charge per admission, so that is.
Oh, I see.
Yep.
And so that went, that's what was raised like in April.
Mm-hmm.
And it says through July 2021. Have they come back down?
So the data that we accessed was available through July. We were able to get an update that was current as of September, and it didn't meaningfully impact the changes that we've seen over this period. I don't know if there's more current data that would reflect a more balanced rate.
I get it. Well, it looks like it probably didn't, which is why the rates, why the revenue stays relatively, is higher than it was before the pandemic.
Yeah.
So you got more, you got admissions back up, not totally to normal, but, okay. So then on the admissions side, the admissions are still materially below where they were. Do we have any idea why?
I think there is still probably some pent-up demand or delaying of care, or people being less willing to go into a hospital setting or seek care there. Specifically, I'm not.
That's not something
entirely
you got into
sure.
with the department. Okay, we'll talk with the department about that. One of the things, and maybe this is for the department, but I'll raise it with you in case you know anything about it, is, I mean, one of the things that struck me during the several crises period, the crisis we just had over the past 2 or 3 months, the crisis we had in the spring, and is that the reason we had to open up all these extra hospital beds was because we didn't have surge capacity. Is that something that the regulatory agencies have addressed in the past and have thought about and decided not to have surge capacity? Do you have any idea?
So I do know that, any additional surge capacity would have ran through the Healthcare Commission. I don't know to the extent of which when those actions took place, but I will say that what the data we're reflecting is really just in those inpatient hospital beds, and not necessarily reflective of surge capacity that the state has added.
Okay, all right, thank you, Madam Chair.
Yeah, let me just apologize to the secretary, deputy secretary, and those of you representing boards and commissions. I have the loan assistance repayment program bill up in EHE, so I'm going to ask Senator Rosa Pepp if he'll take over the hearing from here. And please, committee members, make sure to ask about the important work of the Community Health Resource Commission in my absence. Thank you.
Okay, Secretary Schrader, you're on.
Would you like me to begin, Chairman?
Please.
Okay, Chairman Rosapep and members of the committee, thank you for having us today. I'm joined by Katie Wunderlich, Executive Director of the Health Services Cost Review Commission, Ben Steffen, who is the Executive Director of the Maryland Healthcare Commission, and Mark Luckner, who's the Chairman, Executive Director of the Maryland Health Resources Committee. We also have, if there are specific questions, Emily Brandenburg, our CFO, Webster Yee, Assistant Secretary, and Nick Napolitano. I'm going to start by turning it over to Webster, who's going to answer the first two questions, and then he'll give it back to Katie Wunderlich, who will take the rest from there. And then, of course, we'll hear from the others. Go ahead, Webster.
Thank you, Mr. Secretary. Mr. Chairman, members of the committee, Webster Yee, Maryland Department of Health. We again thank Mr. Garrison for the DOS analysis. Is, as usual, extremely detailed, comprehensive, and insightful. With respect to our testimony, we've submitted written copies to the committee, so we'll just go through it in brief. In addition, we have 3 PowerPoints that have also been submitted and should be part of your packets. And in the interest of time, if the directors want to reference them specifically, they can reference the slides for illustrative points. To the analysis, first 2 questions. The first one about the department commenting on the future availability of funding for the CHRC. Current statutory language allows for the premium tax subsidy to continue through fiscal year 25 and beyond. Absent changes to statute, any future budget decisions regarding funding levels for the CHRC operating grants versus other allowable uses of the subsidy would be at the discretion of the next administration. With respect to the availability and status of the initial HERC funding, the Department of Budget and Management has confirmed that Relief Act funds are no longer available to support the HERC program. Instead, the state intends to use its ARPA award to fund HERC activities in fiscal year 22 via a planned budget amendment. And with that, I turn it over to Ms. Wunderlich for the remainder. The Department of Health does endorse the HSCRC's responses.
Thank you very much, Webster and Secretary Schrader. Mr. Chairman, members of the committee, thank you for having me. My name is Katie Wunderlich. I'm the Executive Director of the Health Services Cost Review Commission. I did provide slides. I'm not going to go through them, but I do have them here if you have questions. I want to just provide a little bit of context before I get into some of the responses that the analyst rose and some questions that have come up already. And first, I do want to thank Mr. Garrison for his analysis. There's a lot of information and a lot of detail and 3 very different regulatory board commissions here, so I want to thank him for his good work. As you all know, the Health Services Cost Review Commission, the HSCRC, is an independent regulatory commission. We have a primary task of setting regulated hospital services to ensure high-quality care and constrained hospital cost growth. However, our role has expanded in the recent years under the total cost of care model. That's also referred to as the Maryland model. In addition to payment and delivery system reform for hospitals, the HSCRC is helping to lead efforts to improve quality, health equity, population health, and coordination for the broader healthcare spectrum. And so I've included in my slide deck a few slides that speak to the breadth of work that HSCRC staff and resources help to support. including quality pay-for-performance programs, which I will note, our hospital quality pay-for-performance programs mirrors that of the federal VBP programs. And we have the first in the nation a disparity measure within our readmissions program, and we're really very excited and proud of that work. We're trying to put health equity and population health in the forefront of all of our policies, and so we have now in our quality programs a disparity measure within readmissions. Our goal is to continue to provide and enhance our quality programs to ensure that we are moving forward with the state's goals. We also have a number of population health and health equity endeavors that bring in community services, community service providers, and connect folks around the state's population health goals of diabetes reduction, behavioral health and opioid use disorders, and maternal child health. And then finally, we also have our bread and butter population-based revenue adjustments that monitor and calibrate the state's hospitals' budgets. So we have a lot of exciting initiatives underway that support the model and support the goals that we have as a state to advance better health outcomes, higher quality, and constrain cost growth in Maryland. So that's just a little bit about who we are and a little bit of what we do. I do want to speak to first the questions posed by the analyst, and then I may also turn to a couple of the comments that were raised already in the hearing. So Mr. Garrison raised a couple of issues. First and foremost around the COVID-19 impact on hospital revenue and hospital delivery. As the HSCRC, we took a broad look at what our action plan needed to be from the start of the pandemic through what is very much still the pandemic is still very much affecting hospital delivery in Maryland. We have, because of the model and because of our population-based revenue system, we have a number of benefits and protections that we can offer to hospitals to allow them to generate revenue that they need, and especially in the beginning of the pandemic, revenue that they needed to make sure they had PPE, to make sure they had staffing, to make sure they could make the changes to their hospital footprints that were necessitated by COVID, that the airflows, the quarantine rooms. And that really was a tremendous benefit to Maryland hospitals to make sure they had the revenue and the resources that they needed. Of course, we also considered federal funding because we do have a duty to the public to keep rates reasonable and reasonably related to hospital costs. And so we consider federal funding that was one of the considerations we had when we were making decisions about increasing the charge corridor or allowing rollover of funds from one year to the next. So those were some of the actions that we took. We suspended some reporting. We allowed hospitals to roll over funds from one period to another. And I think, Chairman Rosapep, that speaks to some of what you're seeing in the spikes in Exhibit 5. And maybe I can just, since we're on this topic, I'll just address that. So the red line, or the line, the monthly revenue for hospitals, you can see pre-March 2020, it bounces around because, to your point, Chairman Rosapep, because we have a global budget, hospitals have to adjust their charges month to month within a 5% corridor to meet over the whole span of the year their global budget revenue. When avoidance tanked at the beginning of the pandemic, when elective procedures were canceled, when there was general avoidance of the hospital, not only the volumes disappeared, but also the associated revenue. So there was a very large dip down in 20, which then necessitated, as hospitals calibrate their budgets, that's why you see the big bump back up. And so we do expect to get back to a more level state, but I think part of the spike and the increase in hospital revenue that you see in 2020 and 2021 are due in part to the catch up from that big dip, some of the GBR mechanics of being able to roll money over from one year to the next.
Could I ask you a question on that since we're here? So do these numbers include all the federal aid, or are these just the rates?
I'd have to refer to Mr. Garrison.
So, Exhibit 5 is just the rates coming in kind of from.
So it doesn't,
data
so it doesn't include federal aid?
No, but the later exhibit, the kind of offsetting bars does include federal.
Right, but they're not related to each other, and so it's hard to relate them to each other.
Yes, so I think this is what is charged at hospitals.
Right, I got it.
The federal funds came in as grants or as, did not come through the rate setting system.
So essentially, my question, I mean, you're agreeing with Mr. Garrison's answer, is essentially what you did because of the dip in admissions and therefore the dip in revenue is you raised the hospital's rates.
So for the last quarter of fiscal year 2020, so it was only the last quarter of fiscal year 2020 that we allowed an increase in rates. And then as we got into fiscal year 2021, there was some undercharge, which means that if a hospital was not able to charge their full revenue, even with that quarter charge expansion, if they weren't able to charge their full revenue, we allowed them to roll those funds over into the next year.
What do you mean they weren't able to charge their full revenue? I don't know what that means.
Because when volumes tanked, when
Yeah.
electives were canceled,
Yeah,
even hospitals that increased their prices by 10% still didn't have enough volume. They'd have to raise their prices 20 or 30 or 40%.
so you say you raised them, but not enough?
Yes, and we didn't allow them to do unlimited quarter expansion. We wanted it to be constrained for the last quarter and also a reasonable increase. We didn't want a 50% increase, say, in charges. And so because the volume dipped so far, we allowed a slight charge quarter increase.
10%?
10%, yes.
Okay, and that's permanent, or that went
No.
down again?
Yes, that was only for the last quarter of rate year 20. We pulled it back in 21. However, we didn't know how long COVID was going to last. So we do
don't.
have some additional quarter expansion that happened for a little bit of rate year 21 and has happened for a little bit of rate year 22. But we tried to keep it to a limited period of time, and we try to keep it to a reasonable.
I got it. So you sort of have temporary rate increases.
Correct.
Okay, but when you look at the chart, when you look at how that plays out, basically, if you look at the first half of calendar 21, because this only goes through July of 21, so I don't know what's happening now. So the first half of calendar 21, they had materially more revenue with materially less admissions than they had before the pandemic.
They did have more revenue, but they also had additional expenses, I think, that aren't necessarily captured in here in terms of remember the scramble for the PPE that happened, and now the pressure right now is staffing.
No, I'm
Yep.
not saying they're not spending the money. I'm just trying to understand it. Do you have data that, for the second half of calendar 21 that the analyst doesn't have?
So we provided through September, and you'll see even through July, it's coming back towards, into the pre-pandemic range. But there were such dramatic changes in volumes, that it has been hard to calibrate because this has gone on much longer than we anticipated. And now we have this confounding factor of staffing, so hospitals can't necessarily fully staff their operating rooms and other things.
No, I get all that. That's a constraint on delivery, and it's an increase in cost. So on the right-hand side, the total dollars, just look at the last one, look at July. This is $0.8 billion, is that what that is? Andrew?
800 million?
Yes. Yep.
Okay, so that's $800 million of total regulated hospital revenue for that month, is that what that means?
Yes.
Is there any place, maybe for Mr. Garrison or for you, where we can relate all the federal aid to the rates? I mean, if you look at all the revenue for the hospitals over the last 2 years through the crisis, how much of their revenue has come from rates and how much of their revenue has come from all the aid? Do we have that?
So, To the extent we tried to capture that on Exhibit 9, and I will say also too that, as Katie mentioned, the HSCRC tried to consider and offset any additional federal dollars coming in against any real increases to the rate structure, as to not have the state be paying for losses that were perhaps already being covered by the federal.
No, I heard the words, but I'm trying to understand the math. I mean, how do we figure the math here in terms of all the revenue the hospitals had during the COVID period, let's say? We're almost to 2 years, and maybe you can't do it, just 2 months behind or something. Was the federal aid, was there any state aid to the hospitals during it? I just don't know.
There was some state aid that came in more recently through the budget amendment, about $25 million.
That's not much, that's around a year.
And then really the other state aid that we're accounting for is some of these rate supports and flexibility and from the financing. I will say that, certainly the DLS's recommendation is really interested in unpacking where the federal support helped and where the state support helped from during this period.
But is that data that you guys have?
On the federal funds, or?
The relation between, I'm just trying to say, look, if it cost $100 to run the hospital system on an annual basis for COVID, during the first year of COVID, the second year of COVID, it cost $125 or it cost $75, whatever it was, how much of that was, of the additional revenue was rates and how much was federal money?
If we think about, for instance, for rate year 20, if a hospital has a global budget of, let's just say 100 million, that's a small amount, but 100 million.
Fine, yeah.
They would continue, we did not, short of the update factor, so each year we update a hospital's GBR for inflation and for their quality payments. Short of that inflation change, their GBR did not change. So they charge the same amount, or the goal is to bring in the same amount for 20, 21, and 22.
You spread it
Now,
over a smaller number of admissions.
We did, so when if a hospital was undercharged and could not bring money, or could not charge their full money, we did consider how much federal funds they received. So if they were undercharged by $5 million.
I got it.
Instead of rolling over that full $5 million, if they got $10 million.
I got it.
Yeah, okay.
But do you have the math on that? I mean, do you have like the actual numbers? If you don't, you can get it to us later. I'm just asking.
Sure, yeah, we could.
That'd be great. Mm-hmm. Okay, thank you. Thank you. Sorry to do a deep dive on this. Please continue.
Sure, absolutely.
I'm sorry, no, Senator Eckert has a question. My apologies.
In the same place, yes. But those numbers, Katie, are cumulative. That's the picture for the whole state, all of the hospitals combined. I'm concerned about how that impacts various areas of the group, of the state. Because we've struggled on the Eastern Shore, as you well know, with Shore and Tidal and Chestertown and McCready, and, we've had a lot of moving parts over the last 5 years. And so I would love to see that translated into a more regional or hospital-based, if possible. And then, did the rate adjustment, was that applicable to all facilities? And all took advantage of it?
Sure, so to speak to rural hospitals and what's happening in rural areas, one of the greatest strengths, or one of the things that the protections that we tried to provide at the HSCRC was to take some of the uncertainty off of hospitals' plate. So they were very uncertain as to where volumes were going to go, what COVID spike might do. And we said, listen, don't worry. We will guarantee your revenue in rate year 20. We guaranteed it in rate year 21. So for instance, for Chestertown and for Dorchester and Easton and PRMC and others, we said, don't worry, we will guarantee that revenue. If what you need to charge is greater than 10%, we'll roll it over into the next year, and we'll continue to allow that to happen, so that rural hospitals specifically can make sure they still have that revenue resources that they need to keep their hospital operating, to support their community, in many instances do vaccination programs. And so that was part of the protection, and part of what we made a conscious decision at the commission to do was to take some of that uncertainty off and say, our global budgets are meant to be a stabilizing factor. In pre-COVID and pre-pandemic times, a hospital in a global budget system, if they have a run on volume, they don't necessarily get they can't run up their revenue. We try to keep it flat because we want to have that stability and to know how much revenue are going to be charged to payers. And so we wanted to, while pre-pandemic, they can't run up revenue and can't charge a bunch, we're not going to let you fail when volumes drop because of the pandemic.
So are many of them in negative revenue states for the first time?
So I can get back to you on, I don't know whether your question is around margins, but I can certainly get back to you on margins that we get audited data. We have the audited data for fiscal year 21. I can show you those margins. And I can also provide to you what the year to date, how undercharged, have they been able to get to their full GBR? And the short answer is for the rural hospitals, they are still undercharged in from rate year 21. So they're still trying to catch up that revenue. But I can provide that to you.
And I'm also interested in capacity.
Capacity.
Capacity is really important, because I know I was hearing from all my neighbors, when they got sick, they were being bypassed and gone to Western Shore hospitals, and that was just driving everybody a little bit crazy at the time. I mean, some people had to go to Laurel, and I understand that. But other cases, I was concerned as I was hearing that, just because of all the hospital changes that were taking place in our area. So thank you. Yeah, I'd be interested in how that played out, because in one way, thinking ahead, Mr. Chairman, I don't think this is going to be the first pandemic or epidemic situation now that we've had this. And how do we think about being responsive in the future so that we are prepared now? And, how do you open units and close units and stockpile supply? I mean, all of that's a piece of this, and I think a lot of our facilities are thinking about that as well. So that's why I'm wondering about the stability and sustainability over time with being able to be responsive to the community and yet being viable at the same time. So, thank you very much, Mr. Chairman.
Sure. And I might just speak a little bit to the capacity because I know, Chairman Rosapep, you also asked about the surge capacity. We were lucky in the beginning of COVID that we had capacity. The state stood up the convention center and Laurel and other safety net and all, to let out some of that volume and some of the pressure. But we were really lucky that we had enough capacity that we didn't have to overutilize, and it wasn't we can get you some numbers on how much, what the admissions were at the convention center in Laurel, but we did have capacity, and our hospitals were able to absorb a lot of that in the beginning of the pandemic. It's a little bit different now because the staffing shortages make our hospital capacity constrained, and so that is certainly something that we're taking a look at. But I absolutely agree with you. This won't be there will be other issues that come up that will need surge planning.
Well, let me pursue that since you responded to it, and we're all concerned about it. It seemed like you guys didn't have any surge plan. I mean, the only reason it seemed like that to me is because I represent Laurel, and I spent 5 years or 6 years with you guys and trying to shut down Laurel, and thank God it wasn't torn down before COVID came. And now we have the workforce shortages, which we knew about. We had workforce shortages before COVID. Now we have extreme workforce shortages. So I'm interested, if there were surge plans that I didn't know about, I'd love to hear what the strategy was with the rate-setting commissions on that. And if there wasn't, why wasn't there? And now that we know there should have been, what's the plan?
Yeah, if I may, on the surge question. Issue number one, getting back, there was a program for 20 years called the Hospital Preparedness Program that was invested in by the HHS ASPR. Unfortunately, as I've looked at it retrospectively, ASPR really wasn't focused on driving surge plans. They had a lot of other things. They were worried about Zika, this, that. And the other thing, the lesson learned from this, because I ran the first surge 2 years ago, is that, and we're working on this as we speak, we're gonna get our surge planning focused on beds. So, for example, we own the 200-bed facility that FEMA gave us. We have it packed up in storage, and we're looking at, okay, do we want to have a major facility in one place, or maybe we want to break that thing down into 4 50-bed pods? We're doing that thinking now. And we've been working with the hospitals in innovation. The first surge, we've been through 6 so far, and each one's been a little different. The first surge, the hospitals just shut down everything, and we opened up about 6,000 beds, and we were able to handle it. We realized in the summer of 20 that probably, although it worked, it wasn't what we wanted to do because you had a lot of delayed care. So then we worked very closely with the hospitals in order to, allow them to surge to a certain level, but maintain a certain amount of care. And so in surge 2, 3, 4, and 5, that was pretty much 5 being the Delta surge earlier or mid last year. And then come Omicron, that was a 60-day surge that went in a V. We hadn't seen that yet. So, I mean, it's a fascinating map when you look at the 2 years. And there will be another one. We just don't know when, and we don't know how big. So we're working now, because this isn't a matter of let's do a lessons learned and hope we can get something in 3 years. We've been updating the surge process as we go along, and we will be ready for the next one when it comes at some point, not too, whenever it happens, probably later this year.
That's great. You made some of that report, I think, on another meeting we were on. But I'm really asking from the point of view of the regulators who kind of control the money and control the incentives for the hospitals. I mean, my impression, correct me if I'm wrong, in the spring of 2020, all over the country, I mean, New York was the extreme case that we all knew about, and then it came to us, is our strategy on dealing with COVID was hospital-driven, which kind of blew my mind, that we had all these restrictions on economic activity, shut down the economy, all the stuff that was very damaging to people. And the fundamental justification was, we don't want people going to the hospital, more people going to the hospital because we don't have the hospital capacity. So fundamentally, the lack of surge capacity in the hospitals, initially with physical space, I guess, or planning for physical space, plus, ventilators and PPP and all that stuff, kind of pulled the whole economy down. And so I'm really asking more from the point of view of, because we have a highly regulated system here, so it seems to me that's where the buck stops, is somehow our hospital system, and I'm not saying we're the only one in the country, but this is us and it didn't work, is we ended up shutting down the economy because our hospital system was not set up for surges. So I'd love for everyone on the panel who has something to say about that to respond to that.
Sure, so I guess the one thing, when the pandemic started, I think none of us knew exactly what was coming. We didn't know, what the disease state would be. We didn't know how many. And I think there was a decision at hospital levels first and then at a statewide level to shut down electives. And I think you are exactly correct. That caused a big dip in hospital revenues. It did grind things to a halt. And I think we've learned that lesson in the subsequent peaks, not to do a statewide ban on electives. On the one hand, we wanted to make sure there was enough capacity for COVID patients. We didn't know how many COVID patients there would be, what would be the need. And so I think we have learned that lesson, that we don't need to necessarily shut everything down.
Right, but I'm not,
But each-
I get that. I'm not talking about taking down the electives. I get that. I'm talking about the strategy that the state pursued, and other states did too, I'm not just putting this on Maryland, to shut down the economy. I mean, I was here 2 years ago, I remember. It was, we need to shut down the economy so we don't fill up the hospitals too much. I mean, that was the argument, which suggested to me that the hospitals were not prepared for a surge medical thing. And the restaurants can't be prepared for it, the transit system can't be prepared for it, but the hospitals and the hospital regulatory agents seem to me the folks who are responsible for preparing for that. So that's really my question, is focus more in on that, not just what it meant within the hospital, but how you avoid a situation where the entire economy comes to a halt because the hospitals don't have surge capacity.
If I could add a couple things.
Sure, please.
Before, so the narrative around this pandemic has changed year to year already.
The facts have, yeah.
And as you said, we made a very conscious decision after the first wave that we were not going to do that again, just for the reasons you mentioned. And working closely with the hospitals, figuring out what's the right amount of capacity. So, and then, so the hospitals have actually been fairly nimble. We've been working with them, as this is a rolling situation, to identify approaches to handle surge so that we don't do that. So, and it's gonna, I mean, the V-shaped surge we just had was completely unexpected because our prior peak had been at.
I know.
It'd been about 1952 was January last year.
Okay,
And then we had two more surges. They were much smaller.
right.
And then the thing that made Omicron so difficult was that its transmissibility was.
So many so fast.
Yeah, so
Yeah,
many so fast, right.
absolutely.
And it went way up and it went way down. So this is an evolving situation. I have to credit the hospitals for working with us and evolving with the situation because it's a very uncertain, virus and it's going to surprise us again. probably.
You and I agree on that, Mr. Secretary.
Yeah.
A lot of people disagree with us, but you and I totally agree on that. I
Yeah.
think the members of the committee agree on that. Ben, did you want to say something?
So I just wanted to add, Mr. Chairman, that, so the kind of the conventional thought about surge capacity is that in Maryland, hospitals are licensed for beds up to 140% of their average daily census. That's what they're permitted to have. Those are licensed beds. Many hospitals beyond the licensed capacity, they have additional physical space that they can seek licensure for in the case of what we would call, up until the pandemic, conventional problems such as a flu outbreak. They could go to the Office of Healthcare Quality and seek to expand their license. So what was quickly clear was that the license capacity wasn't going to be sufficient. Many hospitals then moved to, we're going to bring our physical beds that typically would not be needed online. They could do that automatically through a request to OHCQ. I believe about 1,500 additional beds were brought on through that mechanism. And then the hospitals in that first surge went through this step of seeking emergency CONs from the Healthcare Commission, and about another 1,500 beds were added through that. And that's where the horrific situations were considered, such as turning cafeterias and boardrooms into hospital rooms. Fortunately, most of that didn't need to be happening. At the same time, more than 1,000 beds were created through these alternative medical tent systems that were not needed. But clearly, 140% of capacity, that's kind of the baseline level of beds, is not adequate when you're trying to anticipate major a major surge, and we are, look forward to working with the health secretary and the surge planning team on thinking about how we, there is a cost to having unused capacity in a hospital, and the rate setting system tries to account for that, but we do have to be able to surge up rapidly and appropriately as these different variants probably are going to be coming down the pike over the next several years, perhaps longer.
So you are looking at redoing the system, because, I mean, the cost of not having the surge capacity was enormous, was much higher than I can conceive of budgeting surge capacity, but
Yes,
you're working on that.
we are, and the secretary waived the 140% rule
Right.
for the last 2 years, so that doesn't even apply. That has some ramifications, but, I think it was the appropriate, his decision was
For sure.
appropriate, and we recommended it.
Okay, thank you very, very much. Please continue, and let me turn it over to the chair.
Sure, so I can finish fairly quickly with the last two issues that the analyst raised in his analysis. The first one is on our contractual obligations with respect to the total cost of care contract. We have financial metrics we have to hit and quality metrics that we have to hit each year. The metric that Mr. Garrison identified was our year-over-year guardrail test, which constrains how much Maryland's Medicare total cost of care can grow compared to national growth. We have a constraint of not growing any faster than 1% above national growth and not growing any faster in 2 consecutive years. As Mr. Garrison pointed out, we were very close to hitting that 1% guardrail, largely due to the fact that we had very low growth in calendar year 20, and so to come back and normalize in 21, the growth rate can spike. But I'm happy to report to the committee that we do look to be within that guardrail constraint. This data is through October 21, and we are only 0.8% above the national growth. So we are above national growth, but we have not triggered that 1%. And I'm fairly confident that we will be able to stay within that 1% guardrail. And happy to report that we've met all the other metrics thus far. The last issue that was raised by Mr. Garrison was the MDPCP program and the outcomes-based credit. One, we're happy to continue to report to the committees on MDPCP. And just to give a little bit of context around the outcomes-based credit program, this was designed to offset some of the care management fees and expenses associated with MDPCP and other total cost of care expenses in Maryland. It's really unique. It provides Maryland an opportunity to get credit for population health improvement. Our first one that we have is actually diabetes prevention. And I'm really excited and happy to report that Maryland has had a favorable performance against its cohorts that it's compared to and has earned a $5 million credit that offsets our calendar year 21 total cost of care. So really great news, one, that we're performing well, and two, that we've been able to leverage it to get some credit against our total cost of care calculation. So I'd be happy to continue to report in that MDPCP program, or in MDPCP report, how the outcomes-based credits, how they support and align our broader population health goals that we have statewide. With that, I will conclude my remarks and hand it over to my colleague, Ben Steffen.
Thank you, Madam Chairman. Again, Ben Steffen, Executive Director of the Maryland Healthcare Commission. I'm here to report on our activities over the past year. You have a presentation in your packet as well as our 2021 annual report. I want to commend Mr. Garrison for his very thorough review of our budgetary situation. I also want to note that Tracy DeShields may be with me today, although there was a pressing matter in HGO that she may have attended to. The Healthcare Commission evaluates, regulates, and really nudges the healthcare system along through our data gathering, our public reporting, our planning and regulatory functions that focus on improving quality, reducing cost, and expanding access to healthcare for all Marylanders. We're configured in four centers that largely align with our key functions: health planning, information technology and advanced care delivery, analysis and information systems, which leads our major data gathering initiatives, and quality measurement and reporting, which really is responsible for the quality report efforts that appear on our website, focusing on performance of hospitals, nursing homes, hospices, home health agencies, and a limited amount of information on assisted living and ambulatory surgery centers. Over the past year, we've had major successes in all of these areas, but there's much work to do. We focus our efforts on 5 key priorities, which are to engage and inform the public and the healthcare community. There we convened 5 major work groups on issues related to health planning, inpatient psychiatric services, information technology, and importantly, various activities related to the Maryland Primary Care Program. We expanded our public reporting initiatives through modernizing the website and are working with other government agencies and private stakeholders in sharing that information to ensure that as many as possible in the public have access to that information. A key function is in planning, and I mentioned that earlier. There are over 15 state health plan chapters that provide the framework for the expansion of healthcare services and facilities in the state of Maryland. Maryland has quite an ambitious health planning function, largely centered on the Healthcare Commission. We modernized a number of those plan chapters, most importantly, the plan chapter pertaining to acute inpatient psychiatric services. And then we were very ambitious throughout the pandemic and continuing on to this day to promote the use of information technology, particularly as it relates to the adoption of telehealth. Prior to the pandemic, telehealth for most practices was an afterthought. Once the onset of the pandemic, it became a necessity. The Healthcare Commission worked with providers to bring them to enable them to deliver telehealth initially through any telehealth appliance that they could find, more recently through HIPAA compliant tools and services, and we continue to work with the provider and consumer community on raising awareness. The legislature last year asked the Healthcare Commission to begin a study that's due in December of 2022 on what particular waivers that were put in place as a result of the pandemic that enables broader use of telehealth services. That study is going well, and we expect to deliver our report at the end of this year on waivers that would need to continue. One thing that I would note that in 2022, we did think we were just about to turn the corner on the pandemic and telehealth would ramp downward. That's turned out not to be the case. We've had 4 more surges, and it's very clear that telehealth and the use of remote technologies generally are going to be an essential part of the healthcare landscape in the years ahead. And lastly, we've worked very collaboratively with all stakeholders, our state partners, most significantly the HSCRC and the department in fostering the development of new advanced care models. The most significant, we think, is the Maryland Primary Care Model, where our role is to convene a multi-stakeholder group that looks at makes recommendations on improvement of this program. The program is immensely popular, the largest primary care program in terms of percentage of primary care physicians participating of any program that the CMS has in operation today. It engages significant parts of the population, but it is also true that we need to put more effort into engaging more minority providers so that we have a much more diverse patient participation in the program. The secret to this is to make the program as attractive as possible to smaller providers and providers that have patient populations that have higher acuity, which makes those providers more hesitant to go into new value-based programs, which may impose additional risk on them. The innovations that the state of Maryland has made here are impressive. The latest is the adoption, the integration of what's called an area deprivation index measure that allows practices to receive additional payments if they serve patients in areas that are designated through a metric developed at the University of Wisconsin called the Area Deprivation Index, and those patients are at the highest quintile of acuity. So that we think is a very important step moving forward to attract a wider range of practices, and we think it will lead to fair distribution of rewards under the program. A couple points I wanted to raise on the additional sidelights of the commission. We have, as Mr. Garrison noted, we have supported the establishment of the Prescription Drug Affordability Board. Dr. York is here to talk about that today, and that's very exciting, and the commission has been pleased to provide budgetary support. And then lastly, a question that Senator Eckert asked earlier about the trauma fund. The Healthcare Commission is responsible for administering the $12 million Trauma Physicians Fund, as well as being responsible for, when directed by the legislature to issue the allocation to shock trauma, the $3.5 million support that goes to shock trauma. Several years ago, the Healthcare Commission was asked to play a role there. But focusing strictly on the Physicians Trauma Fund, I think that's a good question. It is evaluated as part of the MHCC audit. The last audit completed in 2019 did show one small corrective measure that we needed to take in terms of as we awarded payments for uncompensated care, the auditors recommended that we had greater segregation of duties in the staff that take care of those payments, which we've taken care of. But I would say in general that to reassure you, Senator Eckert, that the program has been in place for almost 20 years. We have seen a shift due to the establishment of the ACA. Expanded Medicaid coverage has made more uninsured trauma patients, when they appear at a hospital, able to qualify. What has not changed is the payments to level 2 and level 3 facilities, trauma centers, which largely are in more rural parts of the state, with the exception of the trauma center in Prince George's County and the trauma center in Montgomery County. The level 2s and level 3s are in Western Maryland and on the Eastern Shore, and their payments have increased as their what we call standby and on-call allocations, which are allowances to physicians, have increased over time. So I'll pause here, happy to take any questions.
Yeah, let me just thank you very much, and thank you for your partnership with the work on the telehealth bill. That was a comprehensive product put together by multiple partners, and I know you were and your team contributed greatly. Folks, I got to apologize again. We're juggling between bill hearings, so as you see us leave and come, I tried to sneak up between a couple of bills, but now I've got to sneak out again, turning you over to the very capable hands of Senator Eckert.
Thank you very much, and let's see. Thank you, Mr. Stefan, and now we need to hear from the Maryland Community Health Resources Commission. So,
Great.
Mr. Luckner, thank you so much for being here, and thank you for your good work.
Thank you. Yeah, I'll keep my comments very brief. I don't think I'd ever imagined saying this, but Chair Eckert, it's good to see you sitting there. It's really nice to see you. Assistant Secretary, maybe you could just put up slide number 5. I'm not gonna run through this PowerPoint. Just some oral remarks, and then I'm happy to answer any questions. First, I'd like to thank the governor for the fiscal 23 allowance, which, as Mr. Garrison's analysis pointed out, is a total of $73 million. My very first budget hearing in this position was over in the House. It was the 2010 session. In fact, Katie was doing Andrew's job. And you were on Mayor Delaney James' subcommittee. And our budget was $3 million in 2010. And thanks to your support and many others that have come through the legislature, and thanks to the support of folks in the executive branch and a number of folks, now I stand before you today, fiscal 23, we're asked to manage a total of $73 million. And that breaks into 3 buckets. Number one, as Mr. Garrison pointed out, the regular $8 million, that's our authorizing statute. That's the regular blue box. And then the 2 light blue boxes are recent legislative mandates. The Health Equity Resource Committee Act, Senator Hayes' bill from last session, and I'm happy to give a quick update on that. And then third, there was a provision in the blueprint bill that asked us to staff the consortium on coordinating community supports. And Secretary, we're really looking forward to working closely on that. And in fact, my chair would like to talk to you more about that. Okay, so first, let me just thank the governor for just really giving us everything we requested in the 23 budget, which also gives us 5 new pins. And I would thank the department for giving us a pin earlier than usual. We got 40 resumes that were under review. Lisa also helped me out a lot, by the way, for that. And so we'll hire the first of those 5 pins in a couple weeks. But I would just really thank the governor for his support for the Community Health Resource Commission in our budget. And then second, for giving me a great group of commissioners. We have a new chair, Ed Casemar, who I think many of you know, and it's great to have him help guide our commission. And we have another great group of commissioners, and you approved 2 other commissioners earlier this week, Commissioner Gusti and Commissioner Lair. Thank you very much for that. My second comment would be to just thank the members of the legislature for your continued ongoing support. Really, really appreciate the vote of confidence, and of late, you gave us 2 new assignments in the Relief Act, $5 million to get out the door for DDA providers, which we were thrilled to work with the department. It was great to work with Bernie and his team and the association. And so 159 grants went out the door in less than 2 months. That's a lot. And most of those grants are now closed, and they collectively serve 16,000 individuals with developmental disabilities. The second assignment that you gave us, which is longer term, as Mr. Garrison pointed out, is the initial $14 million for the Relief Act. And we are happy to get that funding, and through the last few months, that culminated in us issuing 9 grant awards totaling $13.5 million this Tuesday. And we're going to send a press release. Thanks for approving the release. And so we're thrilled. Those 9 awards, they're in all areas of the state, 3 in Baltimore City, 3 in Prince George's, 1 on the shore, 1 in Southern Maryland, and another one in a rural community. We're just really, really happy to be implementing that program, and we appreciate the strong vote of confidence by the Maryland General Assembly to implement that program. And then the third one, of course, is the Consortium of Community Supports. My final comment would just be to thank Mr. Garrison. Once again, he's hit his analysis for our commission out of the park. I wouldn't change one word. So that, Madam Chair, I would be happy to answer any questions you might have about the work of the Community Health Resource Commission.
Thank you very much. Any questions from our large remaining committee? All of our committee members. I just want to say thank you very much for being very diligent and being sensitive to the cultural nuances throughout the state as we reach out into many of our communities to be able to improve access. I've had the opportunity to appreciate culture in a whole different way, particularly when you're trying to reach folks and we don't have a lot of translators to really understand those nuances of that culture, and then how do we meet the needs of those various populations. So thank you for being able to help. And we'll be interested to see what the outcomes are as we move forward and as that sets the stage for where we're going to build in the future. So thank you. Questions? Yes.
I hear a lot of blame going around for what happened in the pandemic. You know, would I have done a few things differently than you did, Mr. Secretary? Probably. And would have I done a few things different than the governor did? Probably. But would I have been right? I don't know. And neither did you when you made your decisions, for sure. You based it on what seemed to be the right thing to do at the right time. I heard a little bit going like, gee, we would, if the hospitals had been more prepared, we wouldn't have had to shut down the economy. That's not why we shut down the economy. It was to stop the spread, to stop people from dying that didn't get it because of what was done, but who probably would have if we hadn't shut down the economy for a while. So it's regretful that we did, but I think, and I heard you talking about that some, you know, where we go now is having had the pandemic, and I don't know if this will come back or how long it'll be till the next time. I'm the oldest person in this room. It's the only one I experienced, except for maybe polio a little bit back in the 1940s. So could we have been better prepared? Sure, you can always say that. But from the lessons we've learned, I think you're planning to be better prepared if it comes back. But it may not ever come back in our lifetime. And we could have been better prepared probably if we had given all the money that the departments asked in the past, which we didn't do because it didn't seem to make sense. I mean, we can't go out and build twice as many hospitals and let them sit there empty because it might get hit again. So I just think overall, with a bouncing ball that you never knew where it was bouncing next, you made the best decisions you could make. And I think, again, just take the lessons we learned and we'll be a little better prepared next time, but we still won't be prepared and can't be if it hits like this. So I just wanted to say thank you.
Thank you, Senator, and I couldn't have said it better. I mean, you put your finger right on it, and this is very uncertain, and you got to make decisions as you think they should be, but we are learning from this, and I appreciate your perspective. And I do want to say the hospitals have done a magnificent job, so we should be very grateful to
Under
them.
the circumstances they had.
With that, any other words from the analyst or anybody at this point in time? Mr. Secretary and your team, I too would say thank you. You've done a yeoman's job, and I know you're working on how we set the stage for what's going to happen next. Stay tuned, right? I would just share that because our facilities have been so very responsive, I hope we have a degree of flexibility at the local levels with being able to let whoever's in position to bring their skills to the table to go ahead and do that as we work across our agency lines. So I know you will be working on that. So thank you all very much.
Thank you, Madam.
And to your team behind you, thank you as well. Difficult year, but we appreciate your efforts.
And Madam Chair, if I may, I was remiss to not rightfully acknowledge my colleagues, my staff behind me who have put in a lot of work, Megan Renfrew, Mark Hoffman, and Xavier Colo. So thank you for pointing out my misstep. They do so much work behind the scenes, so it's really helpful.
Yes, and I know you were working around the clock. Everybody was, so thank you very much. Appreciate it.
And if I might take a moment of privilege, Madam Chair. I have to acknowledge that these three commissions are critical to the success of the overall health of other. They are smaller agencies, but we work very closely together. The total cost of care model, the laboratory that we have with the Health Resources Commission, and the capacity sizing and policy contributions of the Healthcare Commission. We couldn't do what we do without them. So I did want to acknowledge the importance of these three commissions.
Thank you, and that was very well stated. Very clear, thank you. Have a good afternoon, and we will proceed to the next budget, which I believe is the Department of Aging. Do you have the front sheet? Okay, thank you very much, and I think we're going to begin with Grace Pedersen. I didn't bring my papers with me. Should we bring secretary?
No, you're great.
All right, thank you very much, Grace.
Thank you, Senator. It's my pleasure to present the Department of Aging's fiscal 2023 budget analysis. The budget decreases more than $6 million, and this is mostly driven by the availability of federal stimulus funding that's available in fiscal 2022 that does not continue as substantially in fiscal 2023. Starting with the discussion of fiscal 22, there are almost 20 million federal stimulus funds available in that year, and about half of which goes to meals programs, home-delivered and congregate meals. The fiscal 23 allowance has almost 6 million, and then after fiscal 23, there is nearly 7 million of the federal stimulus funding that will remain unexpended. It's unclear whether additional federal stimulus funds will be brought in into fiscal 22 and 23. So DLS is asking the agency to comment when they expect to use that additional 6.9 million. Now, moving to the fiscal 23 discussion, most of the budget supports various programs. So from Older Americans Act programs to some state programs such as senior care and the senior assisted living subsidy. Further discussion of these programs will be discussed later in the analysis. But looking to the specific changes in the budget, the largest general fund change could be attributed to enhancement funding that's available for the senior care, the senior assisted living subsidy, and the congregate housing services program, as well as information and assistance. The Community for Life and the Durable Medical Equipment Reuse Program, which are relatively new programs for the department, see almost $400,000 increase there. And then there's $100,000 added for the Aging in Place mandate in compliance with Chapter 24 of 2021. Federal funds overall decreased by almost 12 million, and further discussion of those programs is included in Exhibit 4, which breaks down the specific fluctuations for each program. Looking at personnel, the number of regular positions remains the same, but the department gains 4.2 contractuals, and those will be used for federal grant oversight, the Ombudsman program, and the Durable Medical Equipment Reuse program. Some other notable things going on in personnel is that the budgeted turnover rate decreases from 10% in fiscal 22 to 5% in fiscal 23, and the department indicates this will allow them to have more flexibility in hiring and personnel changes as they work to recruit vacant positions. On the same page, Exhibit 8, there's a little summary of each of the department's 3 long-term vacant positions, which the department indicates they're actively recruiting for each of these positions. Now going to the issues, DLS has three. The first one refers to the general fund enhancements. So in fiscal 23, 6 million additional general funds are provided for four purposes. Half of this enhancement funding, 3 million, supports information and assistance, and the department indicates this will be used for various broad purposes, of which are bulleted here that the additional general fund investment will allow the state to capture more federal financial participation for Medicaid-related activities. They'll also be able to increase AAA staffing, support Maryland access points, and overall improve service for Maryland seniors. But limited information was available beyond this at the time the analysis was written, so DLS recommended to restrict this funding pending a spending plan for this $3 million. The other $3 million of the enhancement funding supports three programs: the Senior Care Program, the Senior Assisted Living Subsidy, and the Congregate Housing Services Program. And Exhibit 6 is showing that there have been sustained waitlists in each of these programs, with, especially in Senior Care and the Senior Assisted Living Subsidy, both of those programs saw consistent waitlists, more than 30% higher than the number of individuals they were able to serve through those programs throughout calendar 2021. Moving to the next issue, it pertains to the department's long-term care ombudsman and the public guardianship program. So the long-term care ombudsman program advocates for residents of long-term care facilities, either in assisted living or nursing facilities, and the ombudsman were able to provide increased consultations during the pandemic with the availability of virtual service provision. However, there were some pandemic-related fluctuations in the number of complaints investigated and closed by ombudsman, with an increase in 2020. The department indicates could have been attributed to lack of trust in these long-term care employees during the early pandemic, and then in 2021 the number of complaints decreased, and that could be attributed to staffing shortages in long-term care facilities and limited availability of visitation there. And then looking at the public guardianship program, so individuals could be appointed public guardians if they don't have another suitable guardian available. So the Department of Aging and then the AAAs could be appointed as those public guardians. In fiscal 21, federal fiscal 21, there was a decrease in the number of the public guardianships that the department and the AAAs serve for. But this is also kind of a reflection of the overall decrease in the guardianship petitions that have been filed in pandemic years. As you can see in the red line there, those are the petitions across all ages which have been decreased in pandemic years. And then the third issue pertains to the continued rollout of the new state programs. So the department has focused its efforts on three significant programs: the Senior Call Check Program, which provides daily well check calls to people who enroll in that, the Community for Life program that works to support independent living through providing transportation services or home maintenance or service navigation to members of these Communities for Life that are within a defined geographic area, and then the Durable Medical Equipment Reuse Program, which accepts donations of durable medical equipment, sanitizes and refurbishes the equipment, and then redistributes the equipment to the public at no cost. So looking first at the Senior Call Check Program, this program is funded through the Universal Services Trust Fund. The trust fund is funded with a telecommunications subscriber surcharge each month, and it's managed by the Department of Disabilities. And the Department of Disabilities indicates that if expenditures and funding levels continue forward at fiscal 23 levels, the trust fund could see a shortfall in the out years. So DLS is recommending that the Department of Aging and the Department of Disabilities coordinate to submit a report on various Universal Services Trust Fund expenditures and program activities, but specifically is asking the Department of Aging to coordinate with disabilities to report on the Senior Call Check program utilization and then expenditures. Going to the Community for Life program, as I mentioned, this program supports independent living, and it was first funded In calendar 2018, there were grantees established, and as of January, each of those 2018 grantees have, on average, 32 participants. Exhibit 9 shows expenditures for each grantee with, as of July 2021. So no grantee had more than 60 participants, but a couple saw expenditures in excess of 200,000 or 400,000. And there's also this exhibit is showing the amount of the unencumbered state grant that's still available to each of those grantees. Then moving to the other new program, the Durable Medical Equipment Reuse Program. This program has been able to distribute over $400,000 worth of equipment as of January 2022, and thus far, there's been over $2.5 million invested in this program, counting the working appropriation, and then fiscal 23 proposes to fund the program with an additional $1.2 million, and most of this will support operational costs of the program, such as personnel and other things that go into running the program and refurbishing that equipment. So given the low dollar value of the equipment that's been distributed through the program, and also the relatively low uptake in the Community for Life program, DLS is recommending to request that the department submit biannual updates of program utilization and expenditures in both of those new programs. In addition, so the General Assembly last year restricted $100,000 pending receipt of a report on both the department's waitlist data as well as utilization of the Community for Life and Durable Medical Equipment programs. And the department has submitted those reports. So having complied with those requirements, DLS recommends the release of the $100,000 in general funds. And if there's no objections, we'll process a letter to this effect after the budget hearings. So, and then page 17 starts the recommendations. This is the first recommendation restricting the enhancement funding for information and assistance, pending receipt of a report about how that funding will be used. Exhibit 2 is the recommendation requesting how the department is using the enhancement funding to manage wait lists in the senior care, senior assisted living subsidy, and the congregate housing services programs. And then recommendation 3 is about the Community for Life and Durable Medical Equipment use and expenditures. So that concludes my presentation. I'd be happy to take any questions.
Great, thank you so much, Grace. Any questions from the committee? Hearing none from the committee. Thank you very much, well done, and we are pleased to have Secretary Kramer here from the Department of Aging. So welcome. It's good to see you out there and your team.
Thank you very much. Thank you, Madam Chair and member of the committee. It's great to be here. I spent many, many, many years sitting in this room, so it is very nice always to come back in. It's like coming home. I would first like to thank Ms. Pedersen for her analysis and for the time that she has taken in working with the Department of Aging and our staff to learn our programs, because many of them are complicated, they're new concepts that aren't being used anywhere else in the country. So it really takes an effort to understand. So thank you very much for doing that. It's greatly appreciated. I also would like to just take a moment while I have the opportunity to recognize your area agencies on aging and the work that they have done during this pandemic. You need to know, I'm sure you already know, that our older adults were affected dramatically during the pandemic. We faced problems with getting meals, having food, isolation, and our area agencies on aging from each of your jurisdictions really stepped up to the plate, worked extremely hard to mitigate the pandemic for Maryland's older adults. So I appreciate the indulgence and allowing me to recognize their work. The first discussion item is about the remaining $6.9 million of American Rescue Plan funds and that have come to the Department of Aging and the area agencies. And we are comfortable in telling you that the plan is to spend those funds in 2024. Second discussion item, which is the senior call check, we concur. Discussion item 3 is to comment on our approach to improving the equipment collection and how we plan to increase distribution in our durable medical equipment program. First, I would like to say that this program has exceeded all of our expectations, and I would very much look forward to all of the members of the legislature coming out to see it. We had scheduled a visit for legislators just before session began, but unfortunately, COVID had gotten to the point where we decided it was best not to bring everyone out, and we postponed it. We have a 60,000 square foot building, and it is filled with beautiful, durable medical equipment. Everything from very basic walkers and rollators and bathroom equipment to very sophisticated motorized wheelchairs. We have bariatric wheelchairs. We have pediatric equipment, because though this is a program of the Department of Aging, it is not in any way restricted by age, and we serve Maryland residents of all ages. In the numbers that you received that we have served in distributing equipment, we did not mention a couple of uses that really should have been included. Many of your jurisdictions at the beginning of the pandemic, when they set up their vaccine centers, contacted us for wheelchairs. And we were immediately able to get them the wheelchairs they needed, and the state vaccine locations as well. So there were 100 wheelchairs that we delivered across the state for vaccine centers that we didn't include in the numbers that you received and really should have. So there are a number of one-offs where we've been contacted to assist in the state, and we've been very successful in doing that. The continuation of increasing and continuing distribution, the collection of equipment will continue. We have stayed in touch with all Maryland hospitals to let them know when they have equipment that's abandoned, please let us come and pick it up. The nursing homes and assisted livings hear from us on a regular basis, and we get a tremendous amount of our equipment from them, because otherwise it goes into the landfill. That has been the practice. Every 6 months, they will collect in a roll-off all of their durable medical equipment, and it goes to the landfill. We also are continuing to expand the containers. We get big C containers, and we're putting them at landfills around the state. No advertising. People are just driving up ready to throw the old wheelchair into the landfill, and they see our container, and we have our sign on it, and they just put their equipment into those. And they're filling up regularly. So we continue now to expand, work out agreements with different jurisdictions across the state to collect. You need to know that we have distribution and collection sites throughout the state. So our residents don't need to live near Cheltenham, where our main headquarters is, but our equipment is available statewide in more convenient locations. We continue to advertise in senior newsletters in any way that we can for both distribution and incoming equipment donations. We are working with hospital discharge staff to make discharges more, more readily available and to save time that people frequently wait in the hospital in order to have insurance approve their equipment so that they can go home. We're working on cutting down on hospital stays, which will certainly help the state's total cost of care. We are speaking with veterans groups, community groups, on a regular basis. I'm doing it, our executive director does it. And we may come to the point where we have to advertise to let people know that we're there. It's very difficult without advertising. We're not sure at this point. One thing that wasn't noted here, and we should have, is that we didn't realize when we set this program up to provide tremendous mobility to Maryland's residents, that we were also going to have an environmental impact that has surprised everyone. In this first year of our existence, we're now just about at a year and a half in collections, we have preserved from the landfill the equivalent of 8 3-bedroom homes in the amount of space, cubic feet, that we have kept out of the landfill. We have that much equipment. And so we are pursuing the, that side of what we're doing as well, so that the story in Maryland, the first state in the nation to have its own durable medical equipment reuse program, that we will also be telling the environmental story. So on recommendation 2, we have the, but we have no problem doing, we concur with writing a report to continue to let you know how we're doing here as well. So recommendation 1 is the restriction of the $3 million for information and assistance funding. That funding is to be used for hiring new information and assistance personnel across the state. It will all be spent by your area agencies on aging, on staffing. And we have had the need, as our population of older adults has grown dramatically over the last number of years, to have more people, options counselors, available to speak to everyone who calls in to find out about what services are available to them in the state of Maryland. So we get calls from individuals for their own needs. We hear from adult children all the time. And this funding will allow each of our jurisdictions to hire additional staff to answer those phone calls, and they're highly trained, and to spend more time with each individual. Our lower income residents will get a plan, and we'll work with them to be able to carry out a plan of services for them. All of this intended to be able to allow people to live at home longer. And so we were able to drop everything when we got our analysis, worked with our area agencies on aging, and have just submitted, Ms. Pedersen, I'm sure hasn't had a chance to see it yet, we answered all of the questions that you asked, and I hope succinctly, so that we can hopefully not have the delay in being able to hire the new personnel at our area agency level. And we have a chart showing exactly how many people will be hired and how we believe that will play out in assisting the public. So we would ask, please, that you not withhold that funding. If you allow us to hire immediately as this fiscal year, the next fiscal year begins, we can then utilize it right from the start of the fiscal year and have staffing available to assist your constituents who are calling. This additional funding should also allow us to bring in, it's really the AAAs, to bring in almost $900,000 of additional federal participation funding. And I would suggest, please don't hesitate to call if you review what we've now sent. If there are any questions at all, we and the AAAs stand ready to respond, so you have full information to make that decision. A quick note about our Community for Life program. It has certainly been delayed by the pandemic. As Ms. Pedersen noted in her analysis, the program is designed to allow us to go into homes of older adults to provide the services necessary to keep them home. We haven't been able to go into their homes now for the last 2 years. We are hoping that's lifting. Our real heroes in this are the nonprofits who are operating these communities for life. They're the ones who have put in the largest amounts of money. They're the ones who continue to operate them fully staffed, even though our numbers have been low due to the pandemic. And they still stand behind the program and are all continuing to operate, and in large part with their own funds. That's the beauty of this program for the state. The state only puts in a very small percentage of the total funding necessary. The majority of it comes from the public sector. Excuse me, from the private sector. We have just gotten word that we will have a Medicaid grant, that Medicaid is so interested in this program and the belief that this will keep people out of nursing homes, which cost Medicaid $100,000 a year per person, that they have agreed to subsidize over 1,000 members so that we can, as quickly as possible, bring members on and prove what everyone knows is going to be the result of keeping older adults at home years, if not decades, longer. And so we concur with all of the recommendation 2 is the biannual report for the enhanced funding of the other programs, the housing supports. Recommendation 3, CFL and DME reports, we concur and are happy to provide. And with that, I very much appreciate your hearing our testimony.
Great, thank you very much. Questions from my colleagues? Yes. Senator. Yeah.
Several deaf people recently told me that they had part of their operation in your department. What relationship do you have to the deaf community?
We do not have any specific programming through the deaf community. There has been an issue, this may be it, so let me just throw it out there. There was a concern that the senior call check program was not accessible to the deaf. But when we started the program, we worked very closely with the Department of Disabilities and those and the contractor that makes our calls to make sure that it was accessible to everyone. Our calls, just because we couldn't afford to make them all personal calls to individuals, they are a robotic call. And so the individual picks up the phone, In doing so, we know then that they can get to the phone and they're not languishing on the floor, and then we send out a message to them about something that's of importance to them that day, possibly a new scam that they need to be aware of. In order to serve our deaf residents, our contractor makes those calls personally so that they can use the systems that allow our deaf community to participate in the program. So there has never been any problem with their receiving that daily call, and they certainly, there's no one that we're aware of who cannot access that program.
Yeah, possibly what they were referring to, they've asked me to try to get funding for a deaf community center.
Oh, yes,
And,
yeah.
I think maybe what they were referring to is that the only place they had to go was to a senior center, and they didn't feel as comfortable and have deaf programs there because it was more for everybody.
Understood, yes,
Yeah.
and I have had that discussion, it's been a few years ago, but there were concerns that they were not able to answer about where that should be located, of course, whether the funding would be available for it, but yes, they mentioned to me also that they would like to see that.
I've worked
Haven't
out-
heard anything about where that location would be, which is the first question asked.
Well, I have all that worked out. The funding's the big question now. But thank you.
Very good, please let us know. Senator Rosepep, do you have any questions? Thank you. I do have a couple. I'm sorry about that. First of all, while we were talking about the call check, I didn't realize that it was robotic. It's not person to person? No, it is not.
How many calls do you make?
1,000, it's about 1,000 every day. And so there is no way that it could be a person-to-person at the funding level that we have for that program. And if we make it person-to-person, there will be a lot more interaction that has to take place in those calls. Will be very lengthy.
So how do you evaluate the effectiveness of the program?
It's a very good question. Because of HIPAA, we are not in a position to get the information about people who do not pick up and for whom we call their default caller, who then, if they can't get, if they do their wellness check or they go in and see in person whether they can get in, we don't get that follow-up. What we do is if the individual does not pick up the phone, we then call, we try twice, 3 times, I believe it's 3 times. And then our system then contacts the individual that they provided to us as their default recipient. Sometimes it's the local sheriff's office or the local police department who go out and do a wellness check. So what we do is we call the default individual who then does the follow-up.
And all of these individuals have signed up voluntarily, and
Yes.
they've agreed to the program in advance, so that's how it's established, right?
Yes, Senator. And we have made this, it was a very complicated program to put into effect. It was legislated, and it turned out to be much more complicated than we originally thought, but we have it running extremely well. And we actually even are able to allow our call recipient to schedule the time of day that they would like to receive the call. And that makes a lot of sense, because if they like to sleep late, we don't want to be calling them in the morning while they're, and waking them up. So they can let us know the time of day that they'd like to receive the call, and they can receive the call at home or on a cell phone.
Great, thank you. I did some work with some home care agencies through the pandemic, and that's what I did. I called folks, so I have an appreciation for that, and thank you. One other thing I did not hear, you probably talked about it, and I missed it. What about the wait list? Where are we with that wait list for enhanced funding? And is there a plan to decrease that, or how is,
The
I just
additional,
missed that.
thank you, we did provide wait list information, and we certainly expect that the enhanced funding will assist in reducing wait lists and serving more people. We also believe that our options counselors will have more time to spend with each individual where it's necessary.
And that is that through the area agencies on aging?
Yes.
And that's where those numbers would change. Great, thank you.
Yes,
And
all
then
of it goes to the AAAs.
Thank you so much. And then I would really be remiss if, if I didn't ask about the Community of Care program. Let me see. I know the Community for Life program. We've had discussion, I think, every year, and I didn't want to neglect it, about the Montgomery program. Can you give us an update on that?
The Community for Life program in
Yes,
Montgomery County?
Community of Life program in Montgomery, yeah.
Thank you. We do have a provider a nonprofit provider who has taken on Montgomery County as well as others, but we have not opened it to the public yet. Because of the pandemic, it made no sense to hire personnel to be the service navigator, et cetera, until we were at a point where we could actually have individuals going into homes. So we didn't want to start paying, our provider didn't want to start paying our handy people, our mechanics and our service navigators and our drivers until they could actually start opening the program to the public. And I am hoping that we're talking about doing that now, that our community, that the community numbers of Omicron have reduced dramatically.
And you didn't have any provisional timeline on when that might occur?
No.
Okay.
No, we had no way of knowing.
Okay.
But
And,
we're not funding it. The state's not funding it until they start spending it.
all right, but the funds are still designated and sitting for them when they get going?
Yes.
That's why I want to just be clear on.
Yes, I can tell you, though, that I'm proud to say that I am the first member of the Montgomery County Community for Life.
Okay, great. I think any other questions from anybody? And if not, I think we have some testimony. Thank you very much, Secretary Kramer, for your very thorough response to the analyst comments. And Grace, again, thank you so much for yours. And then I do think we have a couple of folks in the audience. Let me see. Okay, Michelle Douglas, would you please come on up with the Maryland Association of the Area Agencies on Aging? And it's good to see you.
It's good to see you all. It's been a couple of years. Good afternoon, Madam Chair, members of the committee. Michelle Douglas on behalf of the Maryland Association of Area Agencies on Aging, known as M4A. M4A and its 19 area agencies, associated area agencies, represent the front line in Maryland's challenge to meet the complex and varied needs of well over 1 million older adults statewide. We serve Maryland's older and disabled citizens, providing a range of cost-effective state, federal, and locally funded programs to help people remain secure in their community with dignity, independence, and choice as they age. It is always M4A's mission to ensure the safety and well-being of older and disabled adults in Maryland, including throughout the COVID-19 pandemic. This past year continued to be altered by the pandemic. We want to thank the governor for the additional ARPA funds over the past year. It has enabled the network to adapt and adjust to provide some of the most critical needs, including mass vaccination services. M4A also applauds the governor for including additional funds in the proposed budget before you today for several of our most vital state programs, and offers its full support for these increases. The 20% increase in funding for senior care, senior assisted living subsidy, and congregate housing programs will allow the area agencies on aging to reduce their waiting lists for these important programs. They can also look to add more services for people that are already in those programs, or a mix of both, depending upon the local need. M4A also supports the $3 million increase for information and assistance. Information and assistance funding will be designated, as the Secretary said, to hire staff, increase outreach, and can be used as a federal match for the Maryland Access Point to increase the billable service hours. And as the Secretary noted, the department and the AAAs have worked hard together over the last couple of days to provide you with the report that I think you have requested by the budget analyst, who we thank for her wonderful analysis this year again. M4A's strong commitment to provide such valuable and cost-effective services to the vulnerable older population of this state remains steadfast. We urge your support and for these increases and for timely release of the funds so the AAAs can plan effectively.
Great.
Thank you.
Thank you very much. Colleagues, any questions, comments? Thank you very much, Michelle. It's good to see you again.
Good to see you,
Thanks
too.
for representing the M4As. MD4As, is it?
It's 4 because it's the
Right.
Maryland Association of Area Agencies on Aging.
Right, but it's MD first.
Correct.
Got it. Thank you.
Thank you.
And we have one more person here. Let's see. From Partners in Care, Mindy Arnold. Thank you so much for coming down. It's nice to have members in the audience, actually.
Yes, thank you so much for having me. Good afternoon, Madam Chair and the committee. This is my first time speaking with, down in this room here. So I want to thank you for allowing me the opportunity really to speak on behalf of the older adults of our community. So my position is the President and CEO of Partners in Care. We serve seniors. We've been in the community serving seniors for over 28 years. We have over 2,800 members, and Partners in Care is in 5 counties throughout the state. I want to speak as on behalf of the Community for Life. So we are a grantee for Community for Life. So both myself and my board of directors believes very strongly in that program and the impact that it makes on the seniors of our community. So I wanted to come and just express the benefits of having that program to the community, the impact that it makes, the services that we provide, the transportation, the handyman services, the service navigation, which I call member care services, which are like what you were saying with those call checks, those friendly phone calls, the friendly visits to individuals' homes. It allows seniors to age in place with dignity and respect, and it prevents them from going into a nursing home much sooner than they would have to. So we provide the Community for Life program in 6 counties. Speaking on behalf of the Montgomery County, we are the organization that does run the Community for Life program for Montgomery County. So I just wanted to let you know that, and let you know that I have someone that's working out of our Frederick and Hagerstown office to, knock on doors to get us into that community while we're looking for a location to house someone there so that we can open up. But it has been a challenge. We took over this program as COVID hit, and it has been a challenge to serve and to bring members onto this program. However, I feel, and my board of directors feels very strongly and passionately about the program and its ability and the impact that it can make for our seniors of our community. So I just wanted to come down, let you know how honored we are to offer that program in conjunction with our Partners in Care program, which is a volunteer, no fee for service program that supports the individuals that cannot afford to pay for the Community for Life program. So we are covering and serving the seniors across the board.
Great, thank you very much. Minnie, tell us what counties you are already involved
Anne
in.
Arundel County, Frederick County, Talbot County, Caroline County, Washington County, and Montgomery County.
Great, and thank you. And does, Senators, are you familiar with Partners in Care at all? I think Senator Young is, yeah. Partners in Care has been around for how many years, Mindy?
Over 28 years.
Right, and they match up volunteers with needs of other seniors, so
Yes, so
it's,
it's a volunteer-based organization, so we provide transportation, all of the same services that Community for Life provides. Transportation, so someone calls in, they request a ride. The ride doesn't need to be to a medical appointment, though that is where majority of it is. It can be anywhere that a senior would pick up their keys to go is where we will transport them to. We go arm in arm, door to door. We have our volunteers that use their cars, their gas, and take the individual anywhere that they would like to go. The benefits of our program is if they would like to go and they go to the doctors and on the way home, they need to stop at the pharmacy, stop at a grocery store, they can do that as well. Our handyman services, they go out, they fix leaky faucets, handrails, light bulbs, anything we call honey-do list, anything that you need, the individual items that need to be repaired that can prevent a senior member from either making that repair or having to pay for medication. We do those services for them, and it allows them to be able to live and age in place in a safe environment.
Senator Young, yes.
What all are your sources of funding?
It's very hard to get funding, so we request funding from the county, we request funding from different foundations. We have, both in Anne Arundel County and in Frederick County, we have a boutique. It's an upscale resale boutique. Everything in the store is donated, and then everything in that store is, when it's sold, it supports, prior to COVID now, it supports 40% of our organization. And we have 2 paid staff members and about 78 volunteers prior to COVID that run that program and run those boutiques. So it's.
The store in Frederick's a very nice store.
Have you been?
I've donated several hundred pieces of clothing to it.
Awesome, good. It's slowly picking up, and
Yes.
I have faith that it's going to be just as successful as our Anne Arundel County store, but it is very nice.
It's actually a nice store.
Thank you so much. I appreciate your donations. It does support our seniors of our community, so it's greatly appreciated. Make sure you tell all your family and friends.
Well,
Mindy, thank you so very much for taking the time to be with us today.
Thank you
We
so much
appreciate
for
it.
allowing me the opportunity and for continuing to support the Community for Life program.
Thank you.
Thanks.
Thank you. And colleagues, you have a sheet of various other pieces of testimony, including something from MES about all the good work that the program is doing. So any other questions or comments from members of the committee? Well, thank you to our analyst team. Did I miss somebody? Oh, I missed somebody. Sorry. Hang on.
I don't see them there if you want to just call them.
Margot Quinlan. Michelle's done. Tammy Bresnahan.
That was it.
I think that was it. I didn't see. And we have Mindy. Okay, great. Well, thank you all so very much for participating with us today, and have a good afternoon.
Thank you, do the same.
And let's see, colleagues, this ends the committee meeting on Health and Human Services on the Department of Aging and our independent agencies under the Department of Health. The triumvirate, thank you.